are we primed to go for lung cancer screening in India?
Thanks, Balmukesh. Look, excellent question. As I alluded to in my talk, there's a big gap between research and practice, not just in India, but worldwide. Even in countries where there is access and there's not a free health system, but at least the government takes much of the tab on the health system. Access and the number of patients who are eligible who access screening are very poor. Okay, so it's a complex area. So it can be due to a range of things. It can be one, health literacy, then access to health systems. So the first thing to note is it's not a test, it's not a CT scan, it's a program. And as I had mentioned, 13 years after the lung cancer screening trial, a health system like Australia still hasn't launched it. And Chris would agree, a lot of discussions going on what the implications are onto the health system are still being discussed. And it is thought at this point that it'll be mid-2025. So I think there are two aspects to it. Countrywide, in terms of prioritization, I think it has to be thought through. You know the health system better than me, having been at the coalface. The second thing is, are the health professionals ready for it? As I alluded to in my talk, handling the CT scan is a big issue. Like even here in Adelaide, I have to resend the scan for a routine incidental nodule before I ascertain a pathway. So I think that has to be factored in. The third thing in the Indian context is the prevalence of other disorders. So the amount of, the lack of a better term, noise, where nodules due to infections and even post-tuberculous nodules will interfere. So do the same threshold which have been trialed in the NLST and Nelson study, does it apply? I do not know. So I think it has to be factored in and has to be perhaps run as a pilot in the local context and then proceed to implementation. But taking the existing criteria and running it in another context probably is not the smartest thing to do and may create more problems than it answers. Probably a third thing to factor in here is adapting the guidelines, the reliance on PET. And I think the CHEST has a good article on that. In the Asian context, may need to change, and one may need to focus more on getting histology rather than relying on PET, simply because of the prevalence of granular matter disorders. So to answer your question, I think a direct implementation is not advised. Perhaps in the first instance, if there's interest, a pilot, and altering the protocol in the local context. Hope I've answered your question.
Thank you very much. I completely agree with you. So in India, especially, there will be a lot of noise, especially because of infections, tuberculosis, sequelae, and all. I would like to allude to one of them, one study done by one of our assistant professor in our department, Dr. Ashwit, as part of his DM dissertation. He retrospectively analyzed 7 years data from our hospital on pulmonary nodules. And then he was able to characterize around 280 incidentally detected nodules on CT scan, 8 of which was proven to be malignancy by biopsy, and 200 of them were proven to be benign by either microbiology or follow-up according to freshness guidelines. And then he applied the prediction models which were applied in the Western Caucasian population, and he found out that the diagnostic accuracy was not as good as in the literature. And so that proves that we need to have our own data in our population, and probably it has to be done as a project before it can be applied to the population at large. Thank you very much.
Thanks.
Do we have time? Okay, so there are a few questions in the online questions. Quick questions to Jefferson. If you don't have access to inhaled steroids or LABA/LAMA, is there a role for oral salbutamol? for asthma?
For asthma, inhaled corticosteroids have to be the mainline treatment. It would be like treating malaria with just paracetamol. That's how it will be if you give only oral salbutamol. It may give symptomatic relief momentarily, but even that with a lot of side effects. So no role for oral salbutamol.
Quick fire, few other questions. Among absolute eosinophil count, sputal eosinophil count, or serum IgE, which is better for asthma diagnosis?
None of the three are needed for asthma diagnosis. It's only when you have a doubt as to what type of inflammation the patient is having, if he's not responding to inhaled corticosteroids, or you're worried that there may be a neutrophilic inflammation. Only in that scenario, a sputum eosinophil would be the best choice. When you don't have access to it, pheno or a blood eosinophils will be helpful. Total IgE, other than screening for ABPA, or any hyper IgE syndromes, particularly doesn't have any role in asthma evaluation.
Would you recommend switching to synchro breath instead of MDI for asthma bar ACU?
No, they're just purely based on patient preference. Nowadays, a lot of people, nobody likes to carry a space. Turbohaler, synco breath is very, very sleek, very small, easy to handle, easy to carry on. So it's purely based on preference. Some patients don't like synco breath because it's tasteless and they don't get the reaffirmation that when they take a drug that they have actually taken the drug. They prefer the MDI, the spray hitting them, or the taste. So it's just a matter of preference. And while the company do claim that synco breath has slightly higher deposition in the lung, slightly higher, may not be clinically that significant. They're considered equal.